Welcome back to the Gillett Health podcast, where we give you tools to develop a balanced approach for health. I'm Dr. Kyle Gillett, and our guest today is Dr. Alec McCarthy.
Hello, thanks for having me back on the podcast. For a little bit of background, I have a Ph.D. in Regenerative Medicine and Biomaterial Engineering from the University of Nebraska Medical Center. And for disclosure, all of these comments are my own and do not necessarily reflect that of my employer. And I currently work in medical affairs for a medical aesthetics company, which has been super interesting to see sort of the convergence of aesthetic dermatology and regenerative medicine.
Absolutely. Now that those disclosures are out of the way, thank you for coming back on the podcast. We always learn a lot from you. Obviously, we've written papers together and done lots of brainstorming in what I'd consider the cutting edge but not bleeding edge of medicine and science. There's several topics that we have to go over today, but before we dive too deep into the topics, just because several of the podcasts we've done recently, we've been introducing members of what we consider our circle of clinicians and scientists. Tell the audience a bit more about how you got into regenerative medicine and how you got to know us maybe and how you're standing here.
Sure. So I think it probably started when I was a sophomore in high school. So 2012, when I got really interested in 3D printing and engineering, and I was starting to read about these companies that were 3D printing organs. And at the time, obviously, this was like the very, very beginning of bioprinting and really, modern tissue engineering. And so over time, when I went to college, I studied biological systems engineering and biology, and that just sort of naturally transitioned into my PhD program. So I was always super interested in both biology and medicine and engineering. And I started doing research as an undergraduate student, and I basically just continued all throughout my PhD, and then even now working on the industry side of things. I'm still fortunate enough to do research as a co-investigator and publish studies, and so I get to wear both hats as an engineer and also sort of as a clinical researcher. So the best of both worlds. And then how I sort of got affiliated with Dr. Gillett and everyone at Gillett Health. I'd always obviously been interested in regenerative medicine, and particularly, not just in dermatology and aesthetics, but really seeing where else, regenerative medicine can be applied. So functional medicine, of course, you see it applied often, and we just sort of, crossed paths naturally, I would say. Through social media. I'm from Omaha, you're from Kansas City. And so it was a easy drive. The first time we met, you drove to UNMC and you met with a third year medical student and we wrote a large chunk of a manuscript in one go. And since then, we've been pretty productive.
Yeah, thank you for the background. At one point, you mentioned to me that regenerative medicine programs or PhD programs are relatively rare, especially more than 10 years ago. Why that shift?
I think a lot of it has to do with changing perceptions in what regenerative medicine is. So maybe 20 years ago, this concept of regenerative medicine was ludicrous. And even the concept, there's a lot of controversy around it. People, I think back then would automatically, think embryonic stem cells and religion would come into it. And people were skeptical and they had their reservations. But I think, over the last 20 years, you see a tremendous amount of research in regenerative medicine, and that eventually, it becomes hard to ignore. Obviously, all data starts as anecdotal until it's published, peer-reviewed, and there's a meta-analysis carried out. And I think once that happens enough times, you see this paradigm shift, and really see that in the last 10 years. For me, I was the first student to graduate from our regenerative medicine program, and there are more and more popping up, all over the country. There are even a few medical schools now that have engineering emphasis. So, for example, Texas A&M University has an engineering medical school, and so does the University of Illinois. So you're starting to see, I think, a lot of these concepts make their way into clinics and become adopted more readily. And obviously, you need scientists to sort of do the scientific legwork in the field before you can see them move into the clinic.
That's very true. Anecdotally, I've also noticed many people, for example, our star health coach went to both undergraduate school in engineering and medical school as well. By the way, what is regenerative medicine for those that might not be familiar?
So it depends who you ask. I think generally the concept of regenerative medicine is to restore the form and function of diseased, damaged, or aged tissues. And, there's in dermatology, sometimes we refer to these types of treatments as biostimulators, though I don't think that's necessarily appropriate vernacular because, if you could argue that if you're driving endogenous tissue regeneration, that would inherently be a regenerative treatment, but that's sort of like the offhand. So something that will restore the form and the function of a tissue.
What about a bone stimulator after a non-union?
I think it probably depends who you ask. And, I've met other researchers and clinicians who, they wouldn't consider PRP, for example, to be regenerative medicine. I've also met others who wouldn't consider, exogenous ceramics, bioceramics to be regenerative. So I think for me, at least in my definition, I think of something that restores form and function. So for a non-union, absolutely.
In regenerative medicine, there's obviously a lot of applications, but two that we get a lot of questions about is wound healing or the improvement of a pathology, and then also aesthetic. Of course, both go hand in hand, and often when you have a breakthrough in one area, it's applied in both areas. Is there and obviously you're kind of in the aesthetics industry, so that's your viewpoint and mostly our viewpoint as well. But where do you think things are going as far as integrating the use of aesthetic treatments with the treatments to reverse pathology?
So honestly, I think aesthetics generally is on the tail end. So first of all, wound healing was my very first true love. It is what got me into research. And it was the first time that I was able to see that, I could apply engineering principles to the body and change, or intervene in a pathology. And frankly, a lot of regenerative medicine concepts and aesthetics come from orthopedics and from wound healing. And so really, those are the two fields that I have seen in, throughout my Ph.D. and now in industry that really have pushed the way. And aesthetics is just beneficial, the beneficiary of those advancements. The term regenerative aesthetics was first published in the literature in 2020. But regenerative medicine has been around since the early 2000s.
When I think of regenerative medicine or a regenerative medicine clinic, I think of a clinic where I go and they have maybe 2 or 3 therapies, often PRP, and there's kind of like a cookie cutter protocol. Is that regenerative medicine, or where is some of the slippery slope that comes with clinics like that?
Yeah, there's absolutely, I think there can be a slippery slope. And, PRP is a really interesting place to start like this conversation. Obviously, PRP is used thousands of times a day on hundreds of thousands of patients. And, as we're uncovering more and more data, I think we're finding out, more and more. And unfortunately, I think what we're finding out is that it may not be as efficacious as we had once believed. And you will predominantly see this in the orthopedics literature. There's a great orthopedic surgeon, Don Buford, in Dallas, Texas, who does a ton of PRP work, and he constantly is emphasizing, rigorous testing of your PRP, ensuring high cell counts. And then I also am aware of a relatively new study that came out of Ohio State. And this group looked at the relationship between pro-regenerative and pro-inflammatory cytokines from different BMI patients. And, I think this is sort of intuitive when you speak it out loud, but essentially you will have a gradual transition from pro-regenerative cytokines to pro-inflammatory cytokines as a function of increasing BMI. So, to circle back, this begs the question of, is every patient an ideal candidate for PRP? Probably not. And there probably, is a Goldilocks zone where, if you're hypermetabolic or if you're, obese, your PRP might not be as efficacious, as one would hope it might be. Obviously, there are also, other factors like the amount of blood that you're collecting and spinning down, how frequently you're, treating someone with PRP, but you're absolutely right. It's a great place to start. And, I think a lot of regenerative medicine clinics, they have a long way to go. And obviously, as a relatively new field, the rigor is definitely not where it will be in, I think, another 10 years or so.
Yeah. As an obesity medicine physician, I definitely concur with that. I was discussing the concept of PRP with a orthopedic surgeon that does 3D printed joints. They're called conformist joints, but another very interesting emerging technology. And we noted that a lot of our patient population, of course, is obese. A lot of referrals I send have a lot of joint pain, which is a huge, it's kind of the chicken or the egg situation. Did the joint pain or joint pathology come first, or did the obesity come first and then cause that? And probably both. But a lot of these patients have studies or have tried PRP before going to a surgeon like that. And that's just a type of selection bias, right? So if you're selecting for that patient population, all of them are consistently telling that surgeon, PRP doesn't work, PRP doesn't work, PRP doesn't work.
Yeah. The peer-reviewed literature is also very fascinating with this. I think for a while, and maybe even now, so, and it's, a project that we're currently working on, but how do you explain it? And why, when you're looking at PRP for osteoarthritis or for a rotator cuff repair, why is it so variable, group to group? There are off the top of my head, at least 12 studies that, don't show any difference relative to a control or to hyaluronic acid. And, conversely, there's, an equal number that show superiority over, an HA or a control group. So there's definitely a lot of digging left to do, which, I think when it comes to picking a regenerative medicine practice, do a lot of research on who's running it, their background, obviously the rigor that they put into it. Are they sending samples out for testing? How much do you know about what you're getting, put back in your body?
Yeah. Talking about regenerative medicine gives me deja vu talking with our colleague, Dr. Taylor Martin, about artificial intelligence and machine learning. Because everyone says that they have artificial intelligence and machine learning, but few are actually having clinically significant artificial intelligence and machine learning. For example, not many clinics will do basic labs, including hormone labs, including micronutrient labs. Maybe they have malabsorption, history of bariatric surgery, maybe even a biologic aging score, or checking acute phase reactants for inflammation.
Yeah, these are critically important. Obviously, in the field of aesthetics, I think some providers, it's not common to take labs on patients, especially, for med spas or smaller like aesthetic derm practices. That's not, the primary objective. And I think, as we start to uncover more and more, and this probably will be a good segue, into some of the dermatology topics, but it's relevant. And it is not only worth understanding, but it's, as a patient and as a provider, but it's worth leveraging for, more favorable outcomes. And you absolutely can do that.
Mm-hmm. What are some ways that we can leverage for more favorable outcomes? I mean, I'm definitely, I'm a fan of optimal nutrient status. Diet's the first pillar of health, hormone health as well.
Yeah, so I think there are a variety of different ways to do this. And in general, so actually, let me take a step back. So for regenerative aesthetics, this concept of regeneration, really of the skin, we mean restoring the morphology of the extracellular matrix, the ECM. And the ECM is essentially an aggregation of proteins that supports the skin. And as this degrades with age or through sun damage, essentially your fibroblasts in your skin will lose mechanical tension, they'll curl up, and they will cease to synthesize these proteins. And this is a process that, unless you have a solid intervention, will get gradually worse and worse. And so really the goal of regenerative aesthetics is restoring these proteins. And I'll never forget the very first time I met with Shino Bay. He's a dermatologist in Fort Lauderdale, Florida. Him and I were having a very lengthy discussion about regenerative aesthetics. And we were also talking about the observation that patients, on either the hypermetabolic side, so your CrossFitters, your marathon runners, they seemingly have shorter duration with their toxin and with their fillers, or less favorable outcomes to what we would say would be regenerative, treatments. And similarly, older patients and significantly overweight patients also had a similar variability with their outcome. And it really led us, to look at what were the underlying commonalities between those two groups. And so we basically came up with this study design and said, let's try to essentially address any unmet or unobserved skin micronutrient deficiencies prior to an aesthetic treatment, right? So to our knowledge, the very first study really to look at or tie the efficacy of an aesthetic treatment to, the skin metabolism and the skin micronutrients. And for us, the findings were extremely significant. And so our patient cohort was treated with calcium hydroxyapatite filler, which drives endogenous elastin and collagen production and proteoglycan, some of the other proteins in the extracellular matrix. But these proteins are built from amino acids. So if you are amino acid deplete or deficient, you probably have suboptimal protein synthesis. And so in this study, we used a product called NCTF 135HA, which I have the product insert pulled up, and it is a host of 23 amino acids, 2 reducing agents, 6 coenzymes, 12 vitamins, 6 minerals, 5 nucleic acids, and then uncross-linked hyaluronic acid. And so, we spent a long time trying to answer that question. What exactly would it be, that would fix this issue? And we couldn't figure it out, because essentially, you don't know where someone is deficient. And our thought was the best approach is cover as many of those bases as possible. And so when we added a micronutrient, we called it a micronutrient primer, we saw dramatically improved results compared to, just a treatment without addressing amino acids. And the issue with this study, it was conducted out of the country. The product NCTF is not FDA approved for injection in the US. Yeah, and about this time, you and I start having this discussion, and we got the idea, okay, what else can we do? And that's when we, introduced the concept of an oral skin primer. And this was essentially just a combination of, orally ingested amino acids. I'm not going to disclose the company because the prices keep crawling up on us. But I think it's extremely relevant to address the skin micronutrients first. And as a lot of providers, will require that a patient is on a medical grade skincare routine or is following a diet optimally. But this study that we just finished and some others that have just started to look at it, I don't think it can be discussed enough. People need to consider, total health, diet, nutrition if they want an optimal aesthetic outcome.
Mm. Reminds me a lot of hormone health. You have your patient populations that are both hypermetabolizers, borderline overtraining, and you have your patient population that's older, often insulin resistant, metabolic syndrome, and both of them are the most likely to have hormone imbalances or deficiencies as well. And often the first step with that is looking at your micronutrients, your zinc, your selenium, your vitamin D. So there's definitely a lot of corollaries.
Absolutely. Zinc is an interesting one as well. And I think there's a great study in 2012 published in JDD, which is a pretty premier aesthetic dermatology journal. And it was published by John Koshi, and he looked at essentially zinc supplementation for increasing botulinum toxin, Botox, for example, longevity. And, that has to be one of the most common questions anyone in aesthetics gets. When can I get, a touch-up or retreatment? How can I make my toxin last longer? And essentially the results found in this study that 92% of his patients who were supplemented with 50 milligrams of zinc and phytase had an average increase in duration by nearly 30%, right? So that's not an insignificant amount of time. So just simply adding zinc and phytase, bumping out the duration of your toxin by up to 30%, that is a very easy thing to implement for a lot of people.
That's a great outcome. A lot of times we talk about bioavailability of zinc and then also intracellular versus extracellular zinc. So as people age, it is harder for them to maintain adequate intracellular stores of zinc. I usually think 60 plus, but there's obviously not a strict cutoff. So as age increases, you have less and less intracellular zinc. Do we know if it has to do with like the form of bioavailable zinc or whether it's in the serum or in the cell?
They don't propose a mechanism of action. I know that there are some that have tried to uncover it. There are concepts that it may stabilize some of the electron transfer, but I'm not really sure. I don't think anyone really knows the mechanism of action. But even now, if we went on Google and looked up like an oral treatment for increasing toxin duration, there are companies that are advertising this exact zinc protocol. It's very interesting.
What about other things like copper or like vitamin C, collagen? Now we have all these advanced collagen supplements that are prescribed.
There's pretty good data on vitamin C. I've not seen vitamin C for toxin duration. I've seen vitamin C frequently, both orally and topically applied post microneedling, that shows a significant difference in the appearance and the health of the skin. I think it's really interesting. In terms of copper, I've not seen any, not that I'm aware of. But people, especially now, are starting to get really creative. The collagen one is interesting. I get this question, quite a lot, and everyone wants to know if their oral collagen supplementation actually helps. And I always say I don't know, but I still take it. Oral collagen is fairly low cost, and I figure it can't hurt. And I've seen mixed studies. I've seen some where, it works very well, and or there's decent bioavailability. I've also seen studies that show that it does nothing.
Just like any other protein or peptide, not all collagen is created equal.
Exactly.
So,
what are your thoughts on it?
I saw an interesting paper that had to do with eating meat directly off the bone. So, obviously, all proteins have different amino acid contents, different ratios of glycine to other amino acids, different ratio of leucine and methionine to other amino acids. And depending on the content, if you think about it, If you have malabsorption, or if you're on a plant-based diet, usually relatively low methionine diets, usually relatively low leucine diets, then it probably does help more significantly. But I think that it is more helpful for other reasons, for example, tendon or ligament healing, especially after like a period of low estrogen or whatnot, than for skin aesthetics.
Yeah, it also, on the more sciencey side of aesthetics, we talk a lot about the types of collagen. And collagen in aesthetics that's the word, right? Everyone wants more collagen. Sort of in my mind, there really are 4 proteins in the skin that really, really matter for aesthetics. And obviously, collagen is super important. And there are 2 types that, I think are relevant to look at. One type is collagen type 1, and this is the heavy lifter, right? This is the majority of the structural properties of the skin. And collagen type 3 is also really important early on, particularly in wound healing, because that stabilizes collagen 1 synthesis, and it also helps in maintaining anisotropy of collagen, right? So this is favorable alignment of collagen that we want in the skin. We don't want the fibrotic look. That doesn't necessarily reflect a natural look or feel. The other proteins that don't get enough love are proteoglycans, and those are obviously super relevant for hydrating the skin. Endogenous hyaluronic acid, same thing. They hold on to water. They keep the skin tight and hydrated. And then elastin. And no one talks about elastin. And elastin has to be one of the most important proteins in the skin, right? And you and I have talked about this in the past, but I would love to see research looking at the permanent deformation of the skin and whether or not you would have permanent elastic deformation, right? So as you age naturally, obviously your elastin content will decrease, and that results in skin laxity.
Yep.
The hanging skin,
You have
jowling.
your David Sinclair test
Yeah.
on your hand.
Yeah. We actually have developed methods to measure that without taking punch biopsies. It's called cutometry. And I think this data, to my knowledge, there's like 3 publications that use cutometry in the analysis. There's got to be way more. As we start chipping away at understanding how we can leverage these proteins to really, slow aging down, we're gonna have to tap into a lot of these things.
Yeah. A couple analogies that I find useful when talking about this with some patients. Type 3 collagen, as you mentioned, comes in very quickly. Keloids are often formed of type 3 collagen, if that kind of gives you an idea of the elasticity. Often during remodeling, type 1 kind of comes in and helps replace it of some sort. And then as we mentioned, calcium hydroxyapatite, which is in bone and collagen and in the skin, that stimulates all 4 of those important proteins. Estrogen, to my knowledge, only stimulates type 3 collagen formation, but not type 1 collagen formation. So having plenty of estrogen around, even for males, makes a huge difference in tendon healing and collagen healing.
Yeah, you're exactly right.
Yep. Any other notes on that?
So we've touched on, I think there's a couple other points that we can discuss. So some common aesthetic, what I would consider regenerative aesthetic treatments. So bioregenerative fillers, microneedling, using a heat-based or an energy-based device to cause damage to the skin, and that regeneration is considered favorable after damage. I think of these things as planting a seed, and then I think of what I sort of call regenerative adjuvants as fertilizer. And, what kind of fertilizer do you use? Everyone asks this question. You'll hear a lot about exosomes. You'll hear about PRP. You'll hear about, NCTF, the product that we use for this study. You'll hear about amino acids. And I don't think there's a right answer. I think you find a regenerative adjuvant that works and you leverage it as much as possible.
We definitely get the most questions on microneedling, both for the skin and for hair loss prevention. Many people know that I am a fan of microneedling as well. And depending on the depth of your skin, maybe you microneedle at a different length. Educate us a bit more about microneedling and some of its potential applications.
Sure. I love microneedling. It's a fun fact that you probably didn't know this, but the very first, the third study that I ever worked on, I was a senior in undergrad, but it was the first, I think big study that I did, animal models and a long-term, in situ monitoring. It was a microneedling study. And I'll never forget this. This is how I started researching hair regeneration, but I went to check on my rats, I think 14 days after a microneedling treatment, right? And this was in a wound healing context. And they had sprouted so much hair. I was shocked. I'm like, this is crazy. And we actually included it in our publication, just sort of, in the supporting information. But that was the first time I was like, hold on, there's something here with microneedling in hair. So in general, obviously I continue to study it. I've published on microneedling for a variety of different applications. In aesthetics, microneedling is usually leveraged for skin quality improvements or for hair. And for skin, I think it is an absolutely invaluable tool. And, you can have one at home, though I think derma rollers, it may be worth investing in a machined microneedle. Derma rollers, you run the risk of tearing your skin, which obviously is not favorable, but there's a few good things that happen when you microneedle. One, you cause mechanical damage to the skin. And, and once you puncture into it, obviously, you get a very small clot right away. It's usually, you don't run a huge risk of infection, though you should still be as sterile as possible. Don't reuse tips, sterilize everything that you can. But when you cause that damage, it is very angiogenic. And that means we're forming a lot of, new vasculature. This is going to deliver more oxygen, more nutrients to the skin, and the mechanical damage alone may also cause collagen synthesis. And most people will leverage microneedling to deliver topically applied fertilizers, often PRP, autologous PRP, often medical grade skincare, vitamin C, as we discussed earlier. And essentially what that does, the skin does a very, very good job of keeping things out of it. That is its job. And so microneedling, essentially will create some channels to sort of deliver, the payloads, as we call them in research, across the skin. The caveat to that is you have size exclusion principles. And to my knowledge, there has never been any publication showing you could deliver microspheres across the skin. I've seen it and I've heard it discussed at conferences and in offices, but it lacks the data. I've seen some studies that have tried to basically find the size exclusion cutoff, and it's generally, if I remember correctly, around 110 nanometers in diameter. So even with microneedling, it's very difficult to get things across the skin. But for hair, right? So we have to pivot to the hair. The hair results with microneedling are tremendous. And microneedling alone, some of the most significant results, that anecdotally that we have seen, and some of the studies we discussed last night, you can almost approach microneedling for the hair as a multiplier.
It is a force multiplier.
It's a multiplier.
If you plant a seed, you have to dig a hole.
Absolutely. And some of the literature you and I have discussed in the past, you see up to an 11 times effect in hair follicle density compared to a control group in that study. I believe it was topical minoxidil. But obviously, for most things, especially in regenerative medicine, these are all parts of a whole. So, would you get an ideal result just microneedling? You might get a decent effect. Would you get a better result if you coupled this with, something that was a vasodilator, Minoxidil. Yes, these are all parts of the whole. Same thing with aesthetic medicine.
Yep. Some really common questions that I get, and something I've chatted about before, is there a minimally efficacious interval or like a minimal threshold where you have to microneedle this often to have efficacy? Like once a month, once every 2 weeks, once every 6 weeks?
I've never seen an optimization study. I guess, first of all, have you ever seen one?
I haven't either, but I know that microneedling is extremely helpful, and I don't like to do it very often.
Yeah, so that's the main issue, right? So there's a couple things I think, and chime in here. Obviously, you're the physician. If you're using a topical, one, you probably shouldn't use it the day that you microneedle.
Yep.
Especially if it is anything hormone related. You probably don't use it. You don't want that stuff to get into the bloodstream so one, you have to be cognizant of what you're coupling with your microneedling, and two, I generally just the guideline I use is once a week, and this is just because I've seen one study that had phenomenal results with once a week. I know there are some other studies that have looked at optimizing depth, and an optimal depth in this study anyway was 1.5 millimeters. I'm not sure if you and I have discussed that study in the past, but It's a very interesting study. That is to say, obviously it's very painful.
Yep.
And if you had to dial the depth of the microneedle back a little bit, would it still be beneficial? Absolutely. It's just not as optimal.
Females tend to have thinner skin, and also skin thickness also varies person to person. A lot of times females 1.25 seems like a reasonable way to start out with instead of 1.5.
Yeah, but it's interesting, maybe that's something that we look into is an optimal microneedling interval, because I am pretty certain that I know that I've never seen one, and I would love to know.
Yeah. I'm also interested. So a lot of people, for example, let's take Minoxidil. A lot of people start twice a day. A lot of people start topical. And after, 3 to 6 months, they've already garnered most of the benefit they have from a longer hair life cycle. After that, a lot of people switch to once a day. They don't notice a shed. And basically they want to decrease the interval, because it also is not, people don't love putting on topical Minoxidil twice a day. So a lot of people will either switch to a very low dose of oral Minoxidil if they're a candidate, or switch to once a day. Would it be reasonable to, once you're breaking through your Minoxidil, add in once a week or once every 2 weeks microneedling? And then occasionally people say that they've maintained that benefit even going out to once a month or once every 6 weeks.
I think it probably is so patient specific that you almost have to, try it yourself and see. And, anecdotally, you and I have basically used me as a guinea pig for a lot of this stuff. And, that's essentially what we did is tinkered with it until we found an optimal regimen that worked extremely favorably. And for me, that it still is once a week, occasionally once every 2 weeks for microneedling, and then, continuing on a vasodilator. As another thing too that I think we should point out is your transdermal uptake of a topical is largely contingent on how much dead skin or debris you have on your scalp. So it's very important to take care of your scalp, especially if you're using a topically applied, drug to help with hair loss. You want as clean of passage as you could possibly get.
Yeah. The big three for hair loss is kind of debatable. So the big three classically was finasteride, but for most people, I'm a fan of topical or oral, some form of dutasteride. That's another topic. And then Minoxidil, and then microneedling should really probably be part of the big three, but usually it's ketoconazole. I've always wondered if the main efficacy of ketoconazole is actually its androgen receptor weak antagonism, or does it just clear debris and prevent fungal and bacterial infections?
I think it depends. So I've also had the same thought. I think both. if there's sufficient evidence as a DHT blocker, or if it just is a function of it is really good at cleaning your scalp, both of those things are favorable. And one thing I learned in aesthetics and, was difficult for me after leaving academia was you don't always need to know all of the answers. If something works very well and it's safe and it's been demonstrated, is it worth the time and the energy to delineate everything? For me, obviously, I'm always like, I want to know as much as possible. But
the mechanism of minoxidil or the mechanism of modafinil, those are both great choices of not having to know every intricate part of a complicated mechanism.
Agreed.
Yep.
While we're on the topic, one thing that I think your audience may find very interesting, I know that I did, is the concept of topical botulinum toxin. And particularly for men with high DHT, thick skin, a lot of sebum production, oily skin. If they go on HRT, that may manifest with oil production. But the concept of microneedling and then topically applying botulinum toxin has been published and researched pretty extensively with great results. And, the concept is essentially to inhibit the production of sebum. Honestly, I was pretty skeptical early on of this, but I have seen enough data now that I'm pretty convinced. But it's definitely an interesting option for men that may struggle with oily skin or acne.
Yeah, topical agents for like hyperhidrosis is very well characterized and done very often, even in some family practice clinics. But I think that the hyperactive sebaceous glands is definitely another indication of it. It would work a lot of the time. It's not the only way to control sebum production, but it is definitely an underrated, underutilized way to do so. And there's a lot of other applications of increased blood flow. And as people know, I'm a big fan of tadalafil as well as a vasodilator. As age progresses, your phosphodiesterase enzymes can become more and more hyperactive. So if you take an inhibitor of phosphodiesterase, then it's really just kind of bringing it down to a more natural level.
Yeah.
All right. I guess that's unless there's any other parting thoughts, I think that's a pretty good way to sum up the conversation.
Yeah, I think we touched on some really interesting things. The role of diet, how you can leverage that, diets and nutrition and aesthetics. But I hope I can come back and be on another episode. But in the meantime, we will continue our research, and thank you for having me.
Absolutely. Always a pleasure.